or if possible, we'll answer them in writing during the presentation. So I'm very pleased to introduce Dr. Ursula McVeigh. She is the Executive Medical Director of Hospice and Palliative Care at the Providence Group, Alaska. And over the past 2 years, Dr. McVeigh has been leading the education workgroup that has been focused on preparing to educate providers on the implementation of POLST. We have had a collaborative group that has been working together the past 2 years to create a new website, akpolst.org, and to prepare materials to support clinicians with the implementation of POLST. We are starting the education process with a webinar series. This is our second webinar, and we're really glad you could join today. All of the webinars will be recorded and will be available on the website, along with a variety of other educational resources for clinicians and consumers. We are initially focusing our education efforts on helping clinicians and facility leaders understand the changes, and in the future, we'll provide education for consumers. We recognize that this information may be new to many of you and that it is a significant change. So we welcome any input and feedback you may have on what will best support you in the implementation of POLST. On our new website, there is a contact form that allows you to sign up to receive updates on POLST or to ask questions or share with us what resources you need. So we really encourage you to go to the website, akpolst.org, and we'll be sharing that during the presentation to learn more. So with that introduction, I'd like to turn it over to Dr. McVeigh. Thank you.
Great. Thank you, Jeannie. I don't have any financial disclosures to present, and I do want to thank all the work of the DHSS POLST Education Workgroup, especially Jan and Jeannie at ASHNA for hosting the website and for all of the contributions along the way. The goals of this session are for participants to understand the Alaska POLST program, both the form and how we'll transition from Comfort One to using POLST, that participants would understand the intended population for POLST and the voluntary nature of POLST use, that they would know how the form works and the way it's legislated to guide us in how to use the form, and to give us recommendations around how acute care facilities and hospitals can develop policies around honoring and respecting the POLST form. I think this content could be relevant to anybody that's working with POLST, as being able to understand and help patients and families appreciate what happens in the hospital with a POLST is part of the continuum of care and relevant to anyone working with patients or families and completing a POLST form. So POLST is replacing Comfort One as our statewide DNR order. But beyond just being a DNR order, POLST importantly also helps define patients' wishes in pre-arrest situations. As you can see with this gentleman, beyond his interest in making sure we're communicating, that we've communicated and honor his wishes around not to receive CPR, he also has other things he'd like us to know about how he'd like to be cared for. These tools are based on the clinical ethics principles around patient autonomy and shared decision-making, where the patients are the experts in their values, goals, preferences that we sort of sum together as what informs their medical goals of care. And healthcare professionals are experts in knowing what treatments will match those goals and what won't, and to help explain to patients and families how to integrate their goals of care into a plan of care. And then POLST importantly takes the goals of care, translates into a plan of care, and translates that into an active medical order that is to be followed by all healthcare professionals in the state of Alaska. So POLST is more than a form. It's a process that's part of advanced care planning, and it's a conversation. It's an important shared decision-making conversation between a clinician and the patient or their legal representative at the time of completing a POLST, and a conversation at the time of care transitions to confirm POLST is still their wishes, as an illness and preferences might change along the course of a serious illness. And POLST is a process, as mentioned, is part of advanced care planning. And this graphic from National POLST helps put this on this continuum where for all people, we have a standard of care of how we save lives and how we act in emergencies in applying emergency treatments in life-threatening situations. And everyone gets the standard of care. And then along that continuum, for all adults, it's recommended that all adults have an advanced directive, which is the first step in an advanced care planning document. And the advanced directive is important for thinking ahead for potential situations or hypothetical situations in the instance that the person themselves couldn't communicate their wishes. So the advanced directive is only active when the patient doesn't have capacity, and it names who they want to have make decisions for them. And it gives general guidance to help that person make decisions in their stead. And then further along this continuum of as people become less healthy or develop serious illness, that patients might want actual medical orders to opt out of the standard of care in emergency situations, because as people near the end of their lives, critical illness can be end of life care, and people have very specific preferences and priorities around how they're cared for at or near the end of their lives. And then to opt out of a treatment protocol in an emergency, you need a good understanding of how that works. And that's why states regulate statewide DNR programs and put them into statutes and regulations to legislate how it's done, so that we're all consistent in honoring someone's wishes in an emergency, regardless of where they're cared for. So Comfort One was our previous statewide DNR protocol that was put in place in regulation. It's based on the Alaska Healthcare Decisions Act statute that empowers DHSS to put in place the regulation. The statute defines some protections and definitions around the statewide DNR program that we are beholden to, because the statute didn't change when we transitioned from Comfort One to POLST. But there is a new regulation. And so the transition will be that the Comfort One is intended to sunset. The recommendation is that everyone continue to honor and know about Comfort One for those that are already completed, so that we can honor patients' wishes, even if they haven't had the opportunity to update to the new form. And you can continue to use and issue Comfort One in your practice as you learn about POLST. But Comfort One will no longer be resupplied, intended to happen in the summer around June. And so that will force that there won't be a supply of Comfort Ones, that we will all need to adapt and use POLST. But I think as you come through this form, you'll come to see that the POLST really is a better tool to capture patient wishes along the spectrum, that you can use it now. And it's worth knowing that the statute and the regulation are in place now, that POLST is a legal order, that when presented a POLST at this time, one's duty is to honor the POLST and to integrate that into their policies and practices right now, and then to start implementing POLST with patients as you get comfortable and know how to use it. And where to find this information. So the POLST form itself and this Alaska POLST program guide were adopted by regulation. And the program guide is a very user-friendly how-to that gives a lot more descriptions than we had with Comfort One around how to use the form. And then the state website for this is hosted by ASHNA, and that's akpolst.org. That's where you get the POLST form itself. It's no longer ordered from DHSS, and it's printed on regular paper, white printer paper. And so at this website is where you'll always find the most up-to-date form, where you can review the program guide. And there's also clinician and patient family education around POLST available on the website. So the MOST form, for those that use that in your practice, the MOST form looks a lot like a POLST, and the recommendation is to transition the MOST form to a POLST form as well. The MOST form, being designed by a state task force, did have statewide input into its development, but it was never legislated as a legal form. And so there are no state protocols to guide its use. So it's a tool that could share information, but it's not an actionable medical order across transitions of care, which is what is really needed for effective care of a seriously ill population. And it could be confusing. So in your practice, if you're using a MOST form, it's recommended to consider looking at the POLST form, that it probably will serve those goals as well. And so who could be considered for having a POLST form? The language in the reference document describes that the POLST form is intended for patients with advanced illness or frailty, where an accurate prediction cannot be made about death, but it is likely in the foreseeable future. Another question that can help people identify would this patient be appropriate for a POLST form is, would you be surprised if this person died in the next 1 to 2 years? Well, then there's somebody that might have preferences around how their care would be as they faced a serious illness in that time. Anyone who's in a facility who has indicated they don't want to receive CPR should be offered a POLST form so that that preference could be communicated across care transitions. And the POLST form is voluntary on behalf of the patient or their legal decision maker. And if the patient doesn't have capacity, the Alaska statute on surrogate decision-making guides who we then go to as the legal decision maker, which includes in this order, their agent named in an advance directive, their guardian, the person the patient verbally has designated to the supervising healthcare provider as being the person they best trust to speak for them if they couldn't speak for themselves, a spouse, an adult child, a parent, or a sibling. If there's more than one person at a level of decision making, then the guidance is to go by majority or by vote, or everyone in that level can nominate someone to make decisions, for the group. So that's who can assent or participate in the decisions on a POLST. For guardians, they're guided by they're described in the statute that they're not making end-of-life decisions, but a guardian can offer a non-opposition to a physician recommendation around a limitation of treatment. And so a guardian wouldn't technically sign the POLST form, but it would be a discussion where a physician, usually in writing, will request that a guardian consider a limitation of treatment based on the patient's prognosis and on best interest or about information from the patient themselves on their priorities. And then a guardian can offer a non-opposition statement to the DNR or other limitations of treatment that might be ordered. And then who has to honor a POLST? It's all healthcare professionals are required to follow POLST orders when they are presented. And that includes EMTs, emergency personnel, and clinicians in all settings. That when presented, they are active medical orders. In emergencies, that people comply with these and put in place policies to follow these orders. And it also, we're provided with criminal and civil immunity around liability. If in good faith, we followed these orders and if something were to not have been, as expected. And so that's the protection that these are orders that have all of this background around how they have to be used that allow me as a physician to be presented them an order signed by a physician I may not even know, and that I'm going to alter my standard of care based on those orders. And I'm doing that in good faith because there's a lot of legislation around and controls around how these forms are used that I can trust that in good faith, this is an order that the patient has wanted and I'll follow it in an emergency. The law also covers how to handle disputes, that patients' legal decision makers or the patient themselves can enact a POLST or can also void a POLST verbally. So to change a POLST, which would be to update the POLST to have different orders, that does require a legal decision maker or the patient themselves, and it requires a physician's signature to change the POLST. But the POLST can be voided verbally by the patient or their legal decision maker, and the patient's legal decision maker has all of the rights of the patient around their healthcare decisions. So if either a patient themselves or someone who presents as the legal decision maker is presented a POLST that we're intending to follow and that they wish that those not be their wishes, they can verbally designate to void the POLST. POLST is also backed by a very important conversation around shared decision making. And I want to direct people to the webinar that Sharman Figgenshaw is going to be delivering with Ashton on February 8th that will go through a quality POLST conversation and best practices around that. But it's worth just mentioning it's a conversation between a healthcare professional and a legal decision maker, the patient themselves, and that there can be a preparer and it can be a healthcare professional who's not the physician who has the direct conversation with the patient or legal decision maker. and a physician has to sign it into an order to have it be a legal medical order on the basis of the statute that we're beholden to at this time. And to review a bit about what's on the form, we'll start at the top half. This form is modeled after the National POLST form, and it's worth mentioning that a consensus group of representatives from every state prepared this form and debated over every line that was written. And so there's a lot of good information, and everything on this form is very intentional. And if you were to read one thing about POLST, it would be to read this form, and it would cover 95% of everything you need to know about how to use or respond to this form. So it clearly states it's a medical order and not an advance directive. It doesn't name a healthcare agent, and it doesn't give instructions about future states. It's a medical order for patients' current state of health for any emergency that happens now. And it includes their preferences for CPR and their preferences for their initial treatment orders. So it's preferences in the event of a cardiopulmonary arrest, which is when the patient has no pulse and is not breathing. And then for patients that are not in cardiopulmonary arrest, it has these pre-arrest instructions or other emergency instructions that are titled initial treatment orders. And we follow these orders if the patient has a pulse and or is breathing. I'll go into more in depth of what those orders say and what they mean for our policies and protocols and emergencies later in the talk. So the bottom half of this form has a section for additional orders or instructions. So these orders are in addition to those above, and they might include, for example, blood products or dialysis. Another thing people might put in here is if they want to opt out of some of the protocol that was described under selective treatments above, patients might put preferences around non-invasive ventilation in this section, or they might define that they would take oral antibiotics in their home, but they wouldn't want IV antibiotics to be in the hospital. It also contains patients' preferences for medically assisted nutrition and hydration if they wish to make those decisions. Even though those decisions aren't emergency decisions, it is a frequent decision that people might make in advance along the course of a serious illness, and it allows them to document their preferences here, including a preference to have just a trial period of artificial nutrition. It has a section for the patient's signature or patient representative. Now, the signature itself is optional, even though the participation and what the form is ordering requires the assent of the patient or legal decision maker or non-opposition of a guardian. The form to be an active medical order does not actually require the patient's signature on the form, but it is recommended just in case they forget that this was part of a conversation and it was their decision. So it's recommended, but it's not required for this to be an active medical order. And that allows us to have electronic orders and might easily allow Alaska to have a registry, which is a hope for the future, to have a way to have access that every healthcare provider would have access to someone's pulse in Alaska. It does require a physician's signature, and verbal orders are acceptable. And so there are situations where the order would be done by anyone that could accept a verbal order from a physician can document that they have discussed this with the physician and they're giving their verbal order for the form to be signed. On the back of the form, we have to indicate who participated in the discussion from the patient side, and it gives more clarity on who participated in the discussion from the healthcare professional side. So we have that the patient or their legal decision maker, and to just check everyone who participated in the discussion. And you can also add additional optional information around contacts, like patient's primary care provider and their phone number. If patients enrolled in hospice, you can put the hospice agency and their phone number on here. I'll mention that other members of the healthcare team can be trained and have skills in doing POLST discussions with patients. And that includes nurses, nurse practitioners, physician's assistants, and depending on social workers. So depending on the environment where one works, you might have within the care team, you might have other people that are assisting in having these conversations or portions of the conversation with the patients, and that they would work with a physician to have it co-signed by a physician or have it signed by a physician that would feel comfortable signing that in their care practice. And so this is more transparent over who's having the conversations. There is work underway to addend the statute to include that advanced practice providers could sign DNR orders, as that is well within their scope of practice and most common and recommended nationally. And it just requires a statute change for us to allow that to happen on the POLST form. So at this time, it does require that advanced practice providers be the preparer or the professional assisting in the form completion, and that there's a physician identified who can sign it into a medical order. The bottom part of the form, it gives the most useful instructions around completing, honoring, modifying, and voiding the POLST form. I'll let you read later, but that's where almost all that you need to know about the POLST is contained just in the POLST itself. And then in looking at how to interpret a POLST when presented in an emergency setting, like in an emergency department or upon admission to a hospital, I'm going to take you through what's on the orders and how to translate those into a protocol to follow in emergencies. So we'll talk nearly entirely about the decision around what to do in the event of a cardiopulmonary arrest and what to do in pre-arrest situations, called Section A and Section B. So Section A conveys people's preferences for what do they want in the event of a cardiopulmonary arrest. It's to follow these orders if the patient has no pulse and is not breathing. So the first question in a treatment algorithm in an emergency is to assess, is this person in a cardiopulmonary arrest or not? And if they are in a cardiopulmonary arrest, then you look at Section A for their CPR, treatment preferences. And it's a binary decision. People will either receive full CPR and ACLS and be full code, indicating yes, they want to have CPR attempted, or people will designate that they don't want to receive CPR, and that is that they are DNR, do not attempt resuscitation, also sometimes called allow a natural death, that at the time their heart stops and they're not breathing, to allow that that's the natural end of their lives and to let that be the end of their lives. So that's the DNR only applies in the setting of cardiopulmonary arrest. The DNR wouldn't give any instructions on what to do in a pre-arrest emergency. So Section A treatment decisions only apply if a patient has no pulse and is not breathing. If the patient is not in a cardiopulmonary arrest, then you look to Section B to know what are your initial treatment orders in this non-arrest emergency. And the initial treatment orders break down into three groups. That on the spectrum of care of people's preferences along the course of a serious illness, people will designate different levels of care. And one level of care is full treatment, which means using all standard protocols. That somebody would want all treatments done to prevent a cardiopulmonary arrest. And that's what full treatment means. If a person indicates in Section A that they want to receive CPR, it does require, our POLST form does require that patients be full treatment for pre-arrest. So if they want to receive cardiopulmonary resuscitation, they have to also be assenting to have all treatments to prevent a cardiopulmonary arrest, like they would have to accept being on a ventilator, being in an ICU. And as we know, that is sometimes the outcome after a cardiopulmonary resuscitation is being on a ventilator or being in an ICU. So if people are full code for cardiopulmonary arrest and wish to receive CPR, it does require that they be full treatment in a pre-arrest emergency. Now, what I just described is the actual standard of care. That's part of opting into all emergency protocols, that a person who does want CPR, it does want full treatment, doesn't have any need to have a POLST form. They may choose to have one, but they don't need to have one. So if you were reviewing this form with somebody and that was their preference, you might advise them that what they're saying they want is the standard of care, and you might save the POLST form for a different time when they want to opt out of some of the treatment protocols that happen near the end of life. So that's full treatment. If somebody is DNR for Section A, they do have choices around what they want for Section B, and they can choose any one of these three things. So someone can be full code someone can be DNR and still indicate that they want full treatment in a pre-arrest emergency. The other end of the spectrum of where people fall in their preferences for treatment in pre-arrest emergencies is some people only want treatments for comfort. They only want comfort-focused treatments, and they want to avoid being in the hospital. And that is captured in this comfort-focused treatment order section. And then there's people in the middle where they'll accept hospitalization and that level of care, but they draw the line over not wanting to be in the ICU or be on machines, as they might put it, or be mechanically ventilated with an endotracheal tube. So we have the full treatment, which means hospital and ICU care. We have comfort-focused treatments, which means prioritizing treatment in place, but may allow hospitalization for comfort-focused treatments if they can't be kept comfortable in place. And then we have the middle ground that accepts hospitalization, but doesn't want intensive care interventions. And that's the spectrum of what people's goals are and their intentions for the treatment. And then I'll take us through each one and talk about the protocol of how one would respond in an emergency when presenting a POLST form based on these different levels of treatment that people indicate in Section B. So if we start with just full treatments, that's, as mentioned, it's following all standard protocols. So presented in the ER, presented in the hospital. If there's no one to talk to and it's an emergency and someone is having a pre-arrest emergency, and this is what their POLST form says, you're following all standard protocols. And then when there's time to talk, when you're translating those orders for someone who's coming into the hospital, somebody who you're putting in orders in the ER because they'll be receiving care for a while in the ER. If the patient themselves has capacity, or if there's a legal decision maker, it's recommended to confirm their POLST orders that you're seeing on the form and discuss their treatment in the context of maybe there's a new situation, but confirm their POLST and then put in place the orders that would indicate that yes, they want CPR, and no, they don't want any other limitations of treatment. So if a patient has a pulse and or is breathing, and their Section B orders indicate that they want selective treatments. What that means is, in an emergency setting, that's a DNR order. I'm sorry, it is a DNR order always, but that order means the person is DNI, no endotracheal tube intubation, no mechanical ventilation, and no shocks. And the goal that's described for this order is that the goal is to attempt to restore function while avoiding the intensive care and resuscitative efforts like ventilators, defibrillation, and cardioversion. You may use non-invasive positive pressure ventilation, antibiotics, IV fluids as indicated, but avoid intensive care. Transfer to the hospital if needs can't be met in the current location unless they document something differently. So in an emergency, selective treatments in a pre-arrest emergency means don't do anything that would have somebody necessitate their care to be in an ICU in an emergency. And what that means for EMS is not intubating in the field. And what that would mean to an emergency physician is in a respiratory arrest, when you're doing fast treatment protocols, if someone said selective treatments, you would not place them on a ventilator in an emergency. EMS will be, for medical events, be transporting the patient to the hospital. The POLST form, if presented by the patient, would be transferred with them, or the emergency personnel might see it in their hospital medical record. And so the most recent POLST is the active order, that in an emergency, that's an order that would mean to an emergency personnel, in the event of a respiratory insufficiency, we would not intubate as part of our algorithms, but you would do things that could be done on the general medicine floor, and that could include non-invasive ventilation. So in emergencies, you're following it as orders. And then when there's time to talk and put things into a context, you have a conversation about confirming the POLST orders for this new medical event to translate that into hospital orders. So you would confirm. It's a good place to start. You wouldn't have to start broadly and ask people kind of in general what they want, but you could say, based on this POLST, I see you've had these preferences in the context of this current medical condition. This is how I would interpret this. I just want to make sure, do I have that right? And then you would confirm that with the legal decision maker or the patient, and enter it as your in-facility orders for the DNR for Section A, and for Section B, you would put in do not intubate, do not transfer to the ICU, and anything else that you've discussed with the decision maker. If there's no legal decision maker and the patient doesn't have capacity at the time of a hospital admission, you would take the most recent POLST orders as the active orders and put those in place in the hospital, and make a note to be sure to confirm with the legal decision maker, as you always would in a shared decision-making process where you talk with someone to represent the patient about what their care plan is. But in the absence of ability to have a conversation, these are medical orders that should be implemented in the hospital. If somebody put in Section B, comfort-focused treatments, and that goal is described as to maximize comfort through symptom management and allow a natural death, to use oxygen suction, manual treatment of airway obstruction is needed for comfort, avoid treatments listed in the full or selective treatments unless consistent with comfort goals, and transfer to the hospital only if comfort cannot be achieved in the current setting. So this to EMS would mean being called out to someone who had a pulse that said comfort-focused treatments, that they would have their approach focused on what can I do to help somebody be comfortable. And if their comfort couldn't be maintained in the community, they would transfer the patient to the emergency department or hospital for their comfort-focused needs to be met in that location. In the event of emergency protocols, this means do not intubate, no shocks, no non-invasive ventilation. And it also would be best to discuss in the context of comfort treatments around antibiotics and identifying goals in context. So this gives general guidance, opts people out of all of the intensive care interventions and helps them avoid hospitalization. But should they come to the ER, the focus should be looking at what can we do that promotes comfort, and hopefully have a shared decision-making conversation with the patient or legal decision maker about kind of fine-tuning what these goals of care might be along the spectrum of comfort, because sometimes we use antibiotics for comfort in treating a urinary tract infection, and sometimes antibiotics might only serve to prolong a near-death dying process and aren't wanted. So we still need to have conversations, but the default in the absence of being able to have a conversation is to do things that focus on comfort, that could be done in the home setting, and that avoid using your emergency protocols around aggressive life-sustaining treatments. And then the medical orders that would be entered in the hospital would be the DNR for Section A, because everyone who has comfort-focused treatments here would have to be DNR for Section A, and it would be to enter some desired level of medical treatment orders that you would indicate DNI, no ICU, no non-invasive ventilation, no pressors, unless these are otherwise discussed in the context of the medical illness with a patient or legal decision maker. And then more advice around converting POLST to in-facility order sets that within Providence, they call this code status for what to do in a cardiopulmonary arrest, which is either full code or DNR. And then the pre-arrest emergencies are described or defined as the patient's desired level of medical care that we call the DLMC. And I have a screenshot here of what we have in our EMR. And within the desired level of medical care is how we indicate, does somebody want or not want intubation, mechanical ventilation, non-invasive ventilation, et cetera. Other hospital systems use different terms for this Section B part of the POLST. I've worked in a facility that called it the limitation of treatment orders, the LODO. So we would say, what's their code status in LODO? Other facilities might call it their scope of treatment orders. So whatever they're called within your facility, the recommendation is to separate out the preferences that people have in the event of cardiopulmonary arrest to be separate from what they want in pre-arrest emergencies, to have a way that someone can say their DNR for cardiopulmonary arrest and still be able to choose full treatment for pre-arrest emergencies or any or limited treatment, selective treatments or comfort treatments, and that everyone in the facility knows where to find the orders for code status and where to find the orders for pre-arrest emergencies. The most common pre-arrest emergency that we're confirming on admission, whether or not someone has a pulse, is their preferences for intubation. And some would say that's best practice, that everyone admitted to the hospital or all adults would be asked about their preference for CPR or not in the event of cardiopulmonary arrest. And would they accept being on a mechanical ventilating endotracheal tube inserted machine in the event of respiratory failure? And those two questions, if we were to ask everyone those on admission, they would need a way to separate those out in your medical orders, that you would have DNR and separately indicate their preferences for or against intubation. So this desired level of medical care is not meant to be reviewed all of the things with a patient on admission. It's meant to, if they have preferences, that you have a way to capture them as a medical order, and that the only one on this list that is recommended as best practice would be to ask about mechanical ventilation. It wouldn't be necessary to ask everyone at time of admission their preferences around medically assisted nutrition or even relevant to discuss. So that's the recommendation of taking the POLST framework and having that match your hospital framework, which is a good framework to help capture the scope of treatment preferences that people have as they navigate the course of a serious illness. And then to orient a bit of information that's on the website and is coming to the website, is there is a page on patient education resources on the akpolst.org website. And this has an introduction to the POLST for patients and families. There's a patient brochure that is available to print out for them when they have a POLST form that explains to them what to do with the POLST, and it gives them information about the POLST form. There will be a guide that's a pre-contemplative guide for patients that they could use before having a POLST conversation to help them think about their goals of care and orient them a bit to the types of goals and treatment preferences that the POLST captures. And there are videos that we've purchased that review general advanced care planning topics and POLST specifically. And so it can help explain what POLST is, and CPR levels of care, artificial nutrition. And so there's a lot of support around general advanced care planning for patients and families that we're having on the POLST website. So the website has a use to share with, it's worth sharing the website with patients and families to help them think about advanced care planning in general and POLST specifically. And then the professional resources on AK POLST is where you can find the blank POLST form. You can review the regulation that was put in place with this Alaska POLST program guide. There's a list of the frequently asked questions and also links to the video recordings and slide decks. We are looking to also share, as we receive them, policies that facilities have put in place around POLST so that we can share and not have to all reinvent the wheel around putting in place kind of POLST and advanced care planning policies. And we'll also have these presentation slides from these talks available and others that people share with us that are being shared that anyone could use, download, and use in their own talks. So they're public access for educational purposes to use any of these slides. And then some advice around successful use of POLST in hospitals and in emergency departments would be to develop these emergency department and hospital protocols that formalize what you do when a POLST is presented and how to convert it into the orders that you follow in the moment and in your facility. And to offer POLST after a goals of care conversation, or use the POLST form as a tool to guide and frame your goals of care conversation. And again, the February 8th webinar that Sharman Figgenshaw is doing, I think will have a nice review of how to have a thoughtful and effective POLST goals of care conversation with patients and families. And then it is worth mentioning that, different from Comfort One, that POLST will not be kept on file at local EMS or dispatch. So that makes it ever more important that we're providing patients and families with education, that these are their forms to present when they call 911, or for facilities to present when EMS arrives, for EMS to transport the form with the patient and present it to the ER. We are recommending that the forms be kept on file at the patient's local hospital, because that will be the new fail-safe for what if the patient in the moment or the family cannot find or remember where the POLST form is, that then the EMS personnel can call the local hospital and have the form read to them by a medical personnel who could convey the orders on the form to EMS out in the community. So it's recommended that when you're completing these forms, that instead of taking that step of faxing it to the dispatch, that you take the step and fax it to the local hospital. And then in summary, just to get back to the big picture, I'm sure you can see that this is a really important and effective tool to make sure people get the care that they want in the location that they want as they face serious illness and transition to the end of their lives. And for many, many people, it is the acute care setting where they formulate their goals to not return to the acute care setting. And so taking that time in the emergency department and in the hospital to help people think about, would they want to come back to the emergency department? Would they want to come back to the hospital? If it's possible that that next trip might be that they face their end of life in the hospital, they may prefer a system of care and a way to face the end of their lives at home in a way that they can have control and have value for them and the beings that love them. And that's the intent of POLST. Thank you. I think now we'll transition to some time for Q&A.
Great, thanks, Ursula. Great information. There's a couple questions in the chat that I've answered, but I think it's worth talking about. One question is on one of the forms you showed on page 2 of the POLST. It says only licensed healthcare providers are authorized to sign the POLST, but you shared an example that showed VO by nurse practitioner. The question is nurse practitioner acceptable? Can you talk about how verbal orders can be used?
Exactly. So the verbal order was received by a nurse practitioner in this example. And if I can pull it up, but the verbal order is from a physician. Thank you for clarifying that. So the physician has to, at this time, you're not seeing the slide, are you? Can I?
No, you have to go back.
Okay.
We're seeing your slides, but not the
But not
one.
that one. Okay.
Yeah.
I think I might have to scroll through and see what happens. Oh, I think you lost it, right?
Yeah.
Okay, I'll just describe that. The form does say healthcare provider, that's legally allowed to in the state of Alaska sign the form. And at this time, it is a physician that's signing it or a physician that's giving their verbal order for signature. And then if it is a nurse practitioner that's having the conversation, nurse, physician's assistant, they would put their name on the back of the form as the person who assisted the patient. And they would, if they got the verbal order, they could take the verbal order and write that on the front of the form. So for an example, like working with a hospice nurse, it might be a hospice nurse is in the community talking to a patient about the POLST form, and they might call the physician, the primary care physician or the hospice physician, and let them know we had this conversation and these are their wishes. And then that physician can say, okay, I give you my verbal order to put that on the form. And that allows then that form to stay with the patient and to be an active medical order. And then that form can be brought back to the patient's provider, physician, to sign it. But for EMS to know, EMS's instructions are that any form that has a verbal order from a physician is an active medical order. There's no time frame of when that order has to be signed for that to be active in the community.
To clarify, and a nurse practitioner who's an autonomous clinical primary care provider in this community is not legally allowed to sign the POLST form?
That's correct. It's the same statute that also limited nurse practitioners from signing the Comfort One. So
Okay.
that was not changed or put in place or desired by the POLST Workgroup. That was required because the state statute that's part of the Alaska Healthcare Decisions Act, written in the mid-90s, specified that a DNR is only a physician order. And so to change that, because it is best practice to have nurse practitioners be able to sign these forms, but to change that requires an addendum to a statute. Now that is underway. There's work with the nurse practitioner associations of the advocacy arm of that group in Alaska that are working to put that in place, but it needs to be done by statute. There was no way to do it by regulation. Does that help explain?
Yeah, but my other question is, losing the state database for Comfort One, I think, is tragic. Is that something that's going to be added in later, or and the people who are already on Comfort One, do they lose that benefit? Like when EMS shows up to the door, is suddenly EMS not going to have access to the Comfort One database?
Yep, the intention is to have a registry, which is best practice. There really isn't a way to have POLST be kept on file in a dispatched office and have a medical personnel be able to convey those orders to EMS in a field in a safe, HIPAA compliant, effective manner. They didn't see that there was any way to have POLST forms kept on file within the dispatch. And it was learned that statewide, that is a variable practice to begin with. So some regions rely very heavily on that's where it's considered, this is where the Comfort One is. And in other regions, that's not the practice. And so there's regional variations on how dispatch and Comfort One and EMS work. But in areas where they rely on it, it's going to be changing their practice that they need to rely on the local hospital to get those orders for them, not the local dispatch for them. That's the recommendation. But very much so, these are patient documents to present to EMS, and also patients that can decide not to present them if they're intending to not have the treatments followed.
I think this is hugely flawed and dangerous. There's a lot of communities where people get their care through outpatient primary care and don't involve the hospital. And quite honestly, I can tell you that my experience getting records from the hospital is very delayed, not very efficient in time. I'm worried that the POLST form is going to get buried somewhere in the back, scanned into a chart somewhere that no one will have access to. If I call the hospital for someone to read it to, a medical professional is not going to be available to read it to me. There will be a clerk, possibly in HR, in the health information department, that 3 weeks later might fax it to me. I'm gonna
have to stop there. So I don't have any ability to change this, but DHSS made this decision. But I would encourage everyone to work with their local groups. Like, how are we going to do this where we work? What's going to work with us? Partner with your EMS and name that dilemma, because it's not all solved. There's only a statute that we couldn't change, a regulation that was based on some national standards. And now the implementation is a lot of, there's going to be local implementation that I couldn't tell you how to solve, but that you can partner with your local DHSS representatives, EMS, and your primary care groups to think about how to do it. The registry is what you're describing is the reason why Alaska needs a registry.
Yeah.
There was a recommendation around from National Pulse to work out the paper first, because it is nationally, it's patients' advanced care planning documents. Like, we need to empower them, you know, that these are your documents and this is how you can get the care that you want. And that's always got to be part of everything that we're doing when we partner with patients in these. But that I do hope, I would hope for a year from now would be the kind of the soonest I could imagine. But there is someone in charge at DHSS in charge of implementing a registry. So that is the intention. But between now and then, partner and just try to find what's going to work best for your groups around that. Might you ask your local dispatch, you know, can we send you these? You're welcome to work it out locally, but this is kind of what's come down. I hope that helps.
So
it is what it is.
Thanks, Ursula. There are a couple other questions. It seems like a lot of questions around this Comfort One. So there's a question about when we run across Comfort One, she said come fall. So after the 6-month transition,
yeah.
We run across a Comfort One. Should the Comfort One be transitioned to POLST?
Yeah, should. So just to know, I think it's a good idea because people might lose track of what Comfort One is. I think it's a better form because it better defines what people's wishes are. And one of the problems with Comfort One is legislatively, it's only active in a cardiopulmonary arrest. And then culturally, it's a DNR and DNI. So there's some problems with Comfort One. And, you know, so I would just say it's recommended to update. But the patient is voluntary, and maybe they feel like Comfort One is all the forms they need. Then it's their voluntary choice to not look at or put in place a POLST. I hope.
There's another question about in our respective facilities, when we assist patients with the POLST, should we print the form on brightly colored paper for home use as a way to make it stand out?
Yeah, The color of the form was also something debated by the DHSS work groups, and some states have brightly colored forms and they recommend it. They said that's great because you can describe to patients, get that pink form, and EMS might go in, do you have this form? It's on pink paper. Alaska decided not to require that the form be on any bright colored paper because they wanted it to be easily printed anywhere in Alaska and that it could be used at point of service. And so that's why they decided on white printer paper. The other reason why they decided not to have it be colored paper is those forms don't photocopy well. So if the form might be photocopied, it's recommended that it be on white paper. Oregon puts the forms in envelopes. And so it's something we've thought about, that maybe we would have available a POLST envelope that's pink, that could be like provided, ordered from somewhere in the state, and that we could implement something like that. But I'll say there's nothing that's been decided or coming out as a recommendation around that. But I think what you're asking for is important, that we think about how these forms can be easily identified in emergencies, found and communicated. But no description from me or the work groups on how to do that at this time that I would share.
And along those same lines, there's a comment about why not educate patients to keep a copy on the fridge where it's accessible, where applicable, so EMS has it readily available. I think that's a great idea. Again, that is not part of the statewide protocol, but it could definitely be something that a local group would say, this is what we want to really focus our education on in our region.
That's one of the examples on the trifold brochure that you can print out, and it tells the patient, like, this is what to do with your POLST form, and it says give copies to the people that might be involved in decision making, and they recommend consider putting it on your fridge. So I think that nationally, that's a convention, is to look at and put them on the fridge, the refrigerator. That's great to consider that.
Ursula, there's another question, comment. Really glad to see Alaska will be transitioning to the POLST. Can you talk a little more about handling discrepancies between the POLST and advanced directives? Many of our patients have advanced directives or living wills that were drawn up years ago and likely will be out of date.
Right. So advanced directives are most important for naming the healthcare agent who would make decisions if the patient lost capacity themselves. And then the advanced directive should give some, now it's recommended to be more general treatment instructions for future health states. So like the Alaska State Advanced Directive has a portion that says, my wishes if I'm at the end of my life. It might have that someone has a preference around whether or not they want CPR at the end of their life or what their goals are around the end of their life. But that is not a DNR order, because a person might do the advanced directive well in advance of being at the end of their life. And that when is someone at the end of life is actually a debatable context. So what the patient meant when they thought, when I'm at the end of my life, I don't want these things, might not be what I think as a physician when what is end of life and what's critical illness and when is it critical illness and when is it end of life care. So the advanced directive can't be used as an active medical order, but it can be used as a springboard for a conversation to determine what the patient's wishes are, with naming the best person to talk to if they can't talk to themselves, and to give some context around taking the patient's wishes in writing in a medical context and having a conversation. So an advanced directive can only be made into a medical order through a conversation with a legal decision maker as part of shared decision making. So it helps that, but it does not replace a conversation. Whereas a medical order in a POLST, that gives you orders for here and now. It's not future hypotheticals. If I were to be in a car accident and I had a neurologic injury, this is what I would want. If I was at the end of my life, this is what I would want. It means if this happens tonight, this is the care I want. If this happens 6 months from now, this is the care I want. And a doctor has reviewed this to make sure this makes sense for my illness and for what I'm saying are my goals. And so as a medical order, it's something we can respond to. Any person, a healthcare professional, is obliged to respond to it as a medical order. It also requires a conversation to put into context when there is time to talk, because we know people's preferences change along the course of illness, that at any transition of care, we should confirm, are these your wishes? Are these your wishes? So conversations are important in both. Advanced directives are hypothetical future conditions most important for naming the legal decision maker as an agent, and POLST is an order that we follow now, tonight, tomorrow, next month.
That's all the questions in the chat. There is a comment from Mark Carr that I can let people can read on the irony of asking people to follow directions and orders. We have just a couple more minutes. Mark, do you have a comment or a question?
Oh, just follow up. I don't mean to be snarky at all. I just, it does seem that we've learned that following orders is not something we do very well. I think what Dr. McVeigh has said many, many times in this conversation, the most important thing is that you have substantive conversations that can be documented. And this is as good a form as we have all across the nation. It caught hold very quickly and it has spread widely, and it's a very, very good structure. But the gist of it is a good conversation between providers and patients. Thanks, Dr. McVeigh.
Yeah, thanks for sharing that. And I completely agree. I know in other states, I think Washington State has a pretty robust effort to actually train physicians and other providers how to have these conversations with patients. That it's not something that everybody knows how to do. It's something that takes practice and skill. So I think that is something that we could benefit from in Alaska. And if there is anybody who is interested in being part of an effort to help provide this training, it is something we need to work on. And I would say we are now 3 weeks into our Alaska POLST implementation. We have a long way to go, and it really will take everybody working together to figure out how to make this work for patients, family members, providers, facilities. So Ursula, any last comments? There is one more.
Yeah, I think I'll summarize the kind of a response to the last comment around how much should we document. I think it is important to, as we would, document these important conversations in the medical record. And if there is a discrepancy between the advance directive and the POLST, it's recommended to document that there's a discrepancy. The POLST is the medical order. So the POLST is what we would follow, not the advance directive in emergencies. But if you had a discrepancy and you've reviewed it with the legal decision maker, it is good to explain that discrepancy if you could in the medical record.
Great. Well, we really appreciate everybody taking the time to participate in this first step in learning together. And please go to the website, sign up so you'll receive updates when more information becomes available. And we appreciate your time today. Thanks very much.
Thanks, everybody.